So while we're on the topic of the PDGFR mutant GIST, what else is in the landscape? Because there is other exciting developments for KIT mutant GIST as well that's in the horizon. So what are your thoughts about the Invictus data that's been presented and with the drug Avapritinib?
That's a very, very good point. It's a very good issue for us to discuss because as of today, we have imatinib, sunitinib, regorafenib, and that's all that GIST patients have when they're advanced or inoperable, unless they're PDGFR D842V. Those three don't work, but they do have Avapritinib. But there's another agent that's on the horizon, Avapritinib. And Avapritinib is being studied in two different clinical scenarios. One is fourth line versus placebo, the Invictus study. And that data has been presented at a couple of meetings, and it has shown clear activity compared to placebo in terms of response rates, in terms of progression-free survival, in terms of overall survival. We don't know what's going to happen at FDA review, but I think there's a pretty good chance that it will be approved, and then we'll have a fourth-line agent for patients with metastatic inoperable GIST.
I know, I don't think, with fourth line and beyond, having a 9% response rate, even though low, I think is quite encouraging because we didn't have anything in that space before. And a progression-free survival of over 6 months.
Exactly.
It was sad to see patients on placebo, fall off so fast, but that just tells us that these patients with KIT mutant just do need a TKI and shouldn't be taken off their TKI because they progress quite fast.
And a 6-month progression-free survival in fourth line. Remember, sunitinib in second line was a 6-month progression-free survival. So I think it's pretty clear that this agent has some activity and has a place, at least in fourth line. Right. Now the question is, it's also being studied in INTRIGUE, which is a second-line study of Avapritinib versus sunitinib in patients with imatinib-resistant GIST. Correct. And so we'll have to see whether or not this new exciting agent that has a different mechanism of action, it binds to the switch pocket, not to the ATP binding pocket.
So it's
whether
blocking both dual action there, yes.
Yeah, whether or not it's as active or more active than sunitinib, but we'll just have to wait and see about that one.
And the rationale to bring it into second line was also because of a favorable side effect profile. Avapritinib appears to have much lower hand-foot syndrome, might have a little hypertension, but it's otherwise really well tolerated. Yeah. There was a 50% or higher alopecia rate, which is unusual for our patients, but that's something interesting. But so far, most patients have been, have tolerated it well and haven't minded losing their hair. Yeah. So we'll see how it does against sunitinib.
Yeah, I'm very excited for those results. Yes. Now, also, we've talked about Avapritinib already about in the setting of PDGFR D842V mutant GIST, but it's also being studied in third line inoperable metastatic GIST against regorafenib.
Correct.
Again, in a phase 3 study. Voyager. Yes. Phase 3 randomized controlled trial. That's ongoing. It's accrued a lot of patients very quickly.
It's actually completed accrual now, so we're going to get the data sometime this year, I'm hoping.
Maybe ASCO.
Maybe.
Maybe not, but...
Yeah, maybe ASCO later this year, yes.
It'll be exciting to see if we have another new agent in third line.
Right, because they did report in their phase 1-2 study with Avapritinib, the response rates for second and third line patients was actually quite high, even with KIT mutant patients, was in the 20% range. So it would be good to see. It seems more than what we've seen with regorafenib in the past, so I'm kind of waiting to see these results to see if what we saw with the phase 1 study actually pans out in their phase 3 study.
Yeah.
And then in the future, they also have planned to test Avapritinib in the second-line setting next to against sunitinib. And that's a study that is, on hold for now, but we'll see what that data shows in the future once it starts accruing.
Yeah, it's great to see so many new therapeutic opportunities for our patient with GIST. And I know that there's other studies that are non-TKI in the pipeline. There's some studies looking at dual checkpoint inhibitors. There's studies looking at other immunotherapy approaches. There's some even CAR T-cell studies that people are developing in the laboratory. Those are certainly not ready for prime time yet, but it's really good to see those in the future, even past TKI therapy.
Yes, it's an exciting field with newer agents, and I think our challenge is going to be how to select the correct treatment for patients up front to kind of delay development of resistance as much as we can, and then choose the second-line therapy according to their mutation status.
True. Another role potentially for liquid biopsy.
Perhaps, yes.
Perhaps.
Yes.
Well, this has been an excellent discussion. We hope that you found the information presented in this webinar to be valuable to your clinical practice. Thank you for watching OncLive News Network.